Conversations in Frailty, the podcast for Derbyshire clinicians.
Hello, I'm Sarah Morris, GP working within Derbyshire's Community Health Service. Thanks for joining me for this third episode of the podcast. Last month, I spoke to local heart failure lead Martin Melville about the diagnosis and referral of heart failure, and today I'm going to carry on more on the management side. It's great to see a growing number of listeners out there, and do keep spreading the word to any clinicians who you think might find these podcasts useful. Many apologies for the occasional brief episodes of crackling interference during this recording. Apparently it's probably to do with some messages coming into my phone sat nearby. The worst has been edited out and they are only brief. So, I'm back again with Martin Melville for part 2 of our heart failure chat, and this bit we're focusing really around the monitoring and the management of heart failure. Do listen in, as I said, to part 1 if you can, but just to remind us, we also in the background have our 2 heart failure patients, Rita reduced and Penny preserved, and we were following them a little bit through their heart failure journey. So Rita and Penny are both housebound ladies who are suffering with their heart failure symptoms, and the first thing I wanted to ask you about, Martin, really was what non-pharmacological things can we be doing for these frail patients with heart failure?
Okay, so I think there are a number of things we can do that will help them. The first thing that springs to mind, which would also apply to all other heart failure patients, and this is regardless of whether we're talking about Penny preserved or Rita reduced, we should be talking about salt restriction. The salt restriction in heart failure is no different than for normal cardiovascular health, less than 5 grams a day, asking people to avoid adding extra salt. But then what people will do is they'll get very clever and they'll go and buy the low salt option, which then means they have high potassium in their salt, and that can be a problem if we're starting patients on potassium retaining drugs such as ACE inhibitors, ARBs, MRAs and ARNIs. Historically, there's also been a comment about fluid restricting patients, on the understanding that if you've got excess fluid and the diuretics aren't working that well, if you restrict the fluid in, surely that will help. There's no good randomised controlled data to show that fluid restriction makes a difference, especially in community patients. So I don't. If you look historically over the guidelines, they used to absolutely recommend it, and then it got softer and softer and softer. So I don't. Most patients with heart failure report thirst, dry mouth as a problem anyway, and by restricting fluids we add to that. The other common problem that I've come across, and this usually follows hospital admission, well, the doctors told me to restrict my fluid to 1.5 litres. Now the patient has no idea what 1.5 litres is or how much they drink anyway. They hear I need to restrict my fluid. So I go to elderly patients who drink 5 mugs of fluid max a day. They're now on 3 or 4. They are clearly dehydrated. Their blood pressure is low, they have no energy, they're sleepy, their mental capacity is reduced, and they fall. So good, normal hydration is important. But there is a group where I would restrict fluid, and that is when I'm really up against it and we're really on high-dose diuretics and not really going anywhere. And the other group is patients with hyponatremia that's due to hypervolemia. We've followed them through with their blood tests. They keep getting more and more fluid and the salt concentration is going down. It is appropriate to restrict the fluid intake in those patients. And would that be to the 1.5 litres? Yes, I don't go below 1.5 in the community, which is roughly, if people are drinking mugs, I tend to say that's a mug of fluid, breakfast, dinner and tea, mid-morning, mid-afternoon and supper. Just as a kind of rough guide. It does depend on the size of the mug.
And practically wise with the salts, you just say to them, don't add it to your food, but don't go and buy low salt. Is that?
Yes, and I advise them not to add it to the cooking either.
Yeah.
It takes about 8 weeks for the tongue to readjust its salt sensors. In addition to those kind of things, being active, patients often feel, as we said in the podcast last time, heart failure can be quite disabling to hear. And therefore, if I've got heart failure, if I'm active, that could make my heart failure worse. Reminding patients that being active, and certainly what typical patients who are housebound or frail or even active may do in ordinary life is not going to harm the heart muscle. The other one important thing that I think for generally patients, but especially our elderly, is the avoidance of oral non-steroidal anti-inflammatories. Our elderly frail often have renal disease, but they often have pain. And friendly family come along and go, oh, paracetamol not working, try some of these Nurofen. And then we get AKIs, worsening heart failure symptoms. Topical NSAIDs are safe, but oral not. Yeah.
That moves us on, I suppose, to thinking about drugs, and this is a difficult area, isn't it? Because in frailty, de-prescribing is really the big watchword, and in heart failure, we seem to have more and more recommended drugs that we should be thinking about adding in. So, starting with the diuretics, because I think pretty much all our patients we're going to be thinking about diuretics for, because we've got penny preserved and Rita reduced. So, either type of heart failure, reduced ejection fraction or preserved, will benefit from diuretics for symptomatic benefit. Is that's correct?
For the symptomatic alleviation of congestion. And I want to emphasise that because often a patient is breathless, but they don't have fluid in their lungs. So sometimes we may just give them a little bit of diuretic and they feel a bit better, and that's fine. But then they come back because they're not quite as good as they want, and we creep it up, and they come back because it's not as good, and we start chasing a tail and actually making them worse. So it's really important we titrate the dose of diuretic to the fluid congestion we find. So that may be listening to their lungs, looking at their JVP, examining for edema. And in heart failure with preserved ejection fraction, so for penny, for all patients it's important to have the lowest dose, but usually for penny, the dose will be lower than it would be with Rita. There are exceptions, and we do have some patients like penny who are on huge doses, but usually that's the way it falls to start with.
Okay. And would that be for the initial dose? So those patients with a preserved ejection fraction, the initial dose would be lower, or just generally?
Generally lower, but often you'll get away with just 20 to 40.
Okay.
With penny, quite often she's going to remain breathless no matter what we do, even if you got rid of all the fluid.
Okay.
And often I make this clear to the patient because I think it helps manage the expectation. It's not that I won't then review and see if I'm right or wrong in my thinking, but many patients, they feel a little bit better, so they feel there must be more to gain. Surely you can give me some more of that drug because it helped. And we can't forget the effects on blood pressure, especially postural hypotension and their renal function, and whether we're helping them or not. So the rule overall is a low dose in heart failure with preserved ejection fraction, but bear in mind there will be exceptions where they will need quite a lot. To start with, if we talk about Rita, who's not on any of the drugs yet, she'll need a good dose of loop to get going. But as we add the other drugs in, if they have the magic of helping the heart muscle, the need for diuretic reduces. Don't wait till the UNEs deteriorate or the blood pressure drops. Think, if they come back to you and their legs are pristine, let's reduce the diuretic, but allow them to re-increase it if the symptoms start to return. It'll reduce the number of calls back to you, but it empowers that patient to manage their own diuretic. I often say to patients, furosemide in heart failure is like paracetamol for pain. It won't cure or remove the underlying problem, but it will make you feel more comfortable. But once you're comfortable, we stop the paracetamol. And once we're comfortable, we reduce the furosemide.
Never thought of that.
And we have it at home in the cupboard. So I should be able to teach my patients that it's safe to go up and down in a sensible fashion. And of course, with diuretics, we can be very flexible with the time. We do recommend split dosing because of diuretic resistance. But otherwise, the patients can manage those times all around what they do during the day.
And is furosemide normally your first go-to choice? Yeah. Bumetanide, I often feel if furosemide's not working, perhaps we're doing this where we shouldn't be, people think, okay, shall I switch to bumetanide at this point? Is there much evidence of any
no
benefit?
randomised controlled trial that I'm aware of that shows bumetanide is better. And then I think, well, if it was that much better, it would be our first-line drug, always, and it's not. There is evidence that its absorption from the gastrointestinal tract is better than furosemide. So furosemide has random effects over the week. One day you'll take it and it'll do nothing. Another day you'll take it and you'll pass loads of urine. Bumetanide, along with furosemide, tend to have a more consistent effect, but it doesn't necessarily mean you get a better practical result at the end of the day. The other comment I would make about bumetanide is if it's that good, when you swap the patient, you'd actually start reducing the dose. But actually what I find is, even when I've done this historically, you then carry on increasing the dose. So how can it be better? I suspect in the very small percentage of patients, one drug may suit and be better than another. The other thing to say is, because there is a publication out there that says 1 milligram of bumetanide equals 80 milligrams of furosemide, or half a milligram of bumetanide is 40. It's not. Everything else says, and in my personal experience, 40 milligrams of furosemide is equal to 1 milligram of bumetanide, and we've used that in the heart failure services all this time.
Great. That was going to be my next question, so you've preempted it. Great. So, Rita reduced, so that those patients with a reduced ejection fraction, we've got them on the diuretic, but we should definitely be thinking about the ACE inhibitors and the beta blockers. Would be the first things we think about, potentially the spironolactone. Often with the frail elderly cohort that we're thinking about, particularly today, we start titrating these drugs up and we struggle with problems with whether it's renal function, blood pressure, whatever, and they end up on what would be considered suboptimal doses. Is that, in your opinion, appropriate that we're stopping, or should we be trying to risk a slightly lower blood pressure if they're not symptomatic? Where would you sort of go with it?
So I think the first thing I would comment is for Rita. We must remember the ACE inhibitor, the beta blocker and the MRA are prognostically beneficial, but very importantly, they improve symptoms and reduce hospitalisations. And if Rita reduced is 90 years old and says, Sarah, I'm not bothered about living longer, I just want each day to be nicer and don't talk to me about going to the hospital, then here's your drugs. We should try them. We should always remember that, interestingly, we use suboptimal. I'd like to say submaximal. So if all Rita tolerates is 2.5 milligrams of ramipril, and that's her maximum tolerated dose, what we've learnt with all of these drugs, a little is good, a little bit more is better, and the high doses are great. So if I can't tolerate the high doses, then I'll have a middle dose. If I can't tolerate that, at least give me a little, because there is some benefit. So nobody should feel bad if you can only get a patient on a low dose. And it's always a really difficult dilemma, because once the patient has fallen over, it's all a bit late to wish you hadn't done what you'd done. Not that the blood pressure may have been the cause of the fall, but it's worth bearing in mind we go slow and we make that decision.
And if they are, you've got them onto the ACE inhibitor and we've got them onto the beta blocker, and then they are falling over with postural hypotension, which one, and we're thinking we're going to have to cut this back, have you got one that you would kind of working back down the ladder, which one would you stop first, or reduce, I should probably say, first?
My first immediate response would be, which drug have I given for a specific reason? So if my patient has fast AF, I probably don't want to reduce the beta blocker, although if they're relatively sedentary, digoxin might be an option to use, either in addition to a low dose or instead. Digoxin does not manage heart rate in active patients. It's good for resting heart rate. If my patient, and I wasn't expecting them to be end of life, but say has nephropathy with an elevated albumin-creatinine ratio, and I'm thinking, well, really, I know the renal function isn't that good, but the ACE inhibitor will keep it better. Back off the beta blocker. At the end of the day, maybe reducing by a bit of both. I don't think there's a perfect science to it. The patient may tell you they didn't really like one of the drugs anyway, so you might say, well, let's reduce that.
And we've got Rita reduced here, and unfortunately, despite our treatment with we've got her onto actually a good dose of the ACE, a good dose of the beta blocker, possibly some spironolactone as well, which is in the guidance that we can do within primary care. There are, of course, these other drugs that we're seeing increasingly used, the Entresto and the SGLT2 inhibitors. we as primary care clinicians are not initiating them at present, are we? But we're often now having patients discharged back from your services on them. Any particular guidance, because they're for a lot of us less familiar drugs?
I would suggest, in terms of sacubital valsartan, just think of it as an ACE inhibitor or an ARB.
Okay.
It isn't purely, but in the Paradigm heart failure study, they found slightly less renal effect, so creatinine didn't go as high, potassium didn't go as high, and slightly more blood pressure lowering effect. So if the patient's actually stable on it, then just think of it, what do I need to do for if they were on an ACE inhibitor, and manage them in that way. I think that's a sensible way. What I would emphasise is if hyperkalemia occurs, try not to completely stop drugs. Aim to keep patients on one of each of the 4 pillars rather than 2 and none of the others, that way round. So ease doses down. Each of the drugs works differently, obviously within their therapeutic dose range as well. So that's what I would recommend. And with the SGLT2 inhibitors, the only thing I would say is, kind of in primary care, you're probably head's a little bit spinning. You've got the diabetic indications, and then you've got to think, well, they're only really good if GFR's above 60 and possibly above 45, and if they don't work, we're meant to stop them. And then we've got the renal indication, the heart failure indication, and sometimes you've started them for diabetes, and then we've gone, oh, good, because they've got heart failure. And then you go, well, it's not doing much to the A1C.
So
let's stop it.
Yes.
So it's like, if they've got heart failure or renal indication, don't panic, just leave it in, because remember the prognostic benefit, which is predominantly reduction in hospitalisation, with, in Rita's case, a small reduction in death, in Penny Preserved, reduction in cardiovascular death only. That continues regardless of GFR, regardless of what it's doing to A1C, and you get the renal benefit as well. The GFR can fall safely down to 20. In one of the studies, the range of GFR for starting was between 20 and above. So we know we're safe down to 20, which can be a little bit alarming when we get that low.
Yeah. So, okay, going back to Rita and Penny, 3 weeks later, they both unfortunately have another fall, and they're in the local residential care home for a bit of respite. And their leg swelling is now getting above the knee, and they're getting quite breathless just walking down to the dining room. And the care staff are saying, well, Fred down the corridor, we weigh him normally for his heart failure. Should we be weighing Rita and Penny? Not sure. What would you say? Who would you be thinking that we should be recommending daily weights?
I think that's a really good question. Once again, there's no RCT evidence to guide us. What I take a very practical approach here. I think if someone is significantly fluid congested, and where it could be hard for them, their carer, or even yourself, if they're literally full up to their waist, to know, is my increase in diuretic making any difference at all? Because they're just so swollen. And daily weighing helps. It shows you the direction of travel. I think in a care home where it may be inappropriate to ask them to assess Redeemer, I would say during COVID and since, I have taught all patients, where possible, to actually do what I call the press test and do their own assessment, which we never did before. We did it in clinic. And in COVID, we had to ask them to do it, and we do it over the phone. And nobody says to me, I can't do it. I do ask them to sit down and bend forward carefully. I even have, you're on the phone, and they'll, Rita will call over Boris to come and squeeze her legs and you get a result, and you know what you've got. But in care homes, I think the weighing is helpful where there's significant congestion to ascertain whether the diuretics are working. I don't often now ask patients at home to do it daily. I sometimes say at least they're doing it a couple of times a week. It gives me a trend. I will ask them what are their legs like when they've done the press test.
Okay. Rita reduced, unfortunately, she carries on deteriorating, and after multiple hospital admissions, she ends up in a care home on an end-of-life pathway. So when we're getting to this end-of-life point, we're often thinking about reducing drug burden for these patients. Would it be only in the last days that you would be wanting to think about stopping things like the ACE, the beta blocker, the diuretic?
I think I always go with what a patient's expectation is. So if a patient's really sick and fed up of taking drugs, then I'd probably pair it right back to diuretics. But if a patient seems to be happily taking them, not objecting, I kind of think, beta blockers and fast AF is a typical one. We don't want a patient having palpitations and then getting breathless because they've gone into fast AF in their last days of life. If they're happy tolerating them, then it's fine just to leave them in. And then when not, it's usually they come out and we leave diuretics in until even they are just unable to take those.
Okay. Meanwhile, Penny preserved. She's stabilised, and but the AMP's gone out to the care home where she is and doing a bit of an update on all the care plans, and discovers that actually Penny's never had a care plan done. So, any top tips around that?
Any form of heart failure is more likely to have some cardiac death compared to the normal population. What I would say is, with heart failure with reduced ejection fraction, some of our patients will have ICDs in, so the conversation is about deactivating the ICD.
Yes.
Some patients need to be reminded if they've got a CRT pacemaker in, the ICD element can be deactivated. We never deactivate CRT because it's actively treating the heart failure, every beat of the heart. They can be separately done. You can even get a technician to go out to a home in emergency to deactivate it, especially if an ICD is misbehaving. Right. Technicians at Chesterfield can deactivate the devices that are implanted in Sheffield. They have the equipment to do it. I'm pretty sure it's the same down in Derby as well.
Yeah. But Penny preserved defies expectation, and she's still in the nursing home in her mid-90s.
Fabulous.
Happy way to end. So we've had two conversations, Martin. One about previously about sort of diagnosis, referral into the service, and now we've gone through the sort of drugs and the monitoring. Just to finish, anything from our conversation, any particular top tips?
Yeah, I think probably one top tip to encourage. I think there's often a temptation, possibly especially with the elderly, to give them a bit of diuretic, and as long as they've not got too much fluid, they're okay. Certainly the admission data evidence is we should always be aiming for euvolemia. In other words, no congestion but not dehydrated. There's good evidence that patients who are left congested because we struggle to decongest them, possibly because we're worried about their renal function, do worse than those whose renal function we make worse but do decongest.
So be brave.
Be brave. Decongestion is important, and it's a thing we've learned from having our MDTs with David Oschiera, who's the nephrologist who works at Chesterfield Royal. Ever we go to him, they'll say, decongest the patient, please. And that's with GFRs in fairly frightening zones. And you require more diuretic to do that as the GFR drops. So I would always say, please aim for euvolemia, and then remember the lowest effective dose of diuretic, so we're not leaving patients overly dehydrated. Sick day rules. I print them on every prescription I write for ACE, ARB, MRA, ORNI, SGLT2. If the patient has vomiting or diarrhea or persistently, then they temporarily stop those drugs and only restart them once they're drinking normally. I know it's part of the SGLT2 prescription automatically in TPP. It's not been added to the others because some patients, such as hypertensives, may have good kidneys and maybe not need to stop it. My concern is with our heart failure patients, they're not under my care a few months later, and a few years later, if nobody's told them that message and they carry on, they may end up with an AKI that doesn't improve. So I ask the patients to temporarily stop them. Patients discharged from hospital where they've had an infection, they've become hypotensive, their drugs have been stopped. Discharge letters often say to the GP, we've stopped the antihypertensives, please review the patient and restart if needed. Please just have a thought, were they antihypertensives or were they prognostically and symptomatically important heart failure drugs that we should restart? And I try and remind all my patients, if those drugs are ever stopped, to go to the GP and ask, should they be restarted for my heart failure? To kind of give a prompt and keep patients on the drugs as long as is possibly practical to do so.
Fantastic. Well, I've learned a lot from both of our chats, and I'm really grateful for your time coming to talk to me today.
That's a pleasure, Sarah. Always been really useful, and please, anyone in Derbyshire, if you want to talk through any advice, please ring one of the cardiac heart failure teams either at Walton or Florence Nightingale. You'll get help.
Thanks very much. So once again, lots of useful learning points for me here, and hopefully for you listeners out there too. I think there's quite a clear message for us to try to avoid leaving these frail elderly heart failure patients with a significant amount of congestion, but equally not to dehydrate them with unnecessary fluid restriction. And also that the drugs beyond diuretics, they really do have a symptomatic benefit and they help to reduce hospital admissions. So definitely worth making the effort to persevere titrating these. Martin and I also spoke briefly off record about the cardiac rehab services in the county. It's undeniably great for heart failure patients, but it's not commissioned locally for this indication. So spaces have been made available but are limited. So any alternative therapy input or community programs such as the seated exercise programs are well worth utilising. Referrals for the limited places need to really be targeted to those who will benefit most. So as always, this is the opinion of one expert in the field, so in individual patient cases, always consider the local and the national guidelines and use your clinical judgment. Find us on Spotify or the DCHS YouTube channel. And for the next episode, we'll be thinking about mental health in the elderly, focusing on depression. Do join me then.
Conversations in Frailty. Thanks for listening.